I think, maybe we should also talk a little bit about what factors, there are other options that we can use, particularly in the frontline setting for our patients with CLL. What factors do we think about in terms of using a BTK inhibitor or perhaps a venetoclax or even, chemoimmunotherapy? I must confess, I don't use a lot of chemoimmunotherapy anymore. Although I'm sure there are exceptions to that roles where that's still, patients where that's still important. When I think about using a BTK inhibitor instead of venetoclax or chemoimmunotherapy, I'm not sure that some of the necessarily the traditional prognostic factors necessarily sway me. I mean, of course, someone has a p53 mutation, then we know that chemoimmunotherapy is just really not indicated. It's hard to do that. But comparing it to venetoclax-based therapies, such as venetoclax and obinutuzumab, which is a frontline regimen, I think that we don't have enough data in terms of which is the best therapy in those two different scenarios. I confess that I get a little bit worried about patients with p53 mutations and using a time-limited therapy. I'm not sure that my concern is rational, but I think we do need more data, and there's certainly trials ongoing examining that. I mean, how do you make that decision?
Yeah, I agree. I think there's a bit uncertainty now with the availability of venetoclax to really make that decision. I think in general, everybody agrees that we are moving away for the vast majority of patients from chemoimmunotherapy to the new agents. We could still make the point that chemoimmunotherapy has some role, or should at least be discussed with young, fit patients who are IGHV mutated, where we saw in long-term analysis of the FCR data that there is a fraction of about half of these patients who have long-term survival and still in remission beyond 10 years. So for those patients, I still bring it up as an option, but many patients are going to opt against it, especially because of the concern of secondary AML and MDS, which is a valid concern and which has bad prognosis. So I think the general trend is to move to the new agents, and then you have in the frontline setting BTK inhibitors available, and now more recently you have venetoclax obinutuzumab available. And how do you make that choice since we don't have comparative trials, at least not now? I think my decision is usually based on, it's a case-by-case decision where you usually go with the BTK inhibitors, at least I do, based on long-term data, on a lot of clinical trial data with the BTK inhibitors. And venetoclax is for many patients somewhat inconvenient because you have to dose escalate in the first 4 weeks. You have to monitor closely for tumor lysis. So that makes it a bit more complicated, at least in the beginning. On the other hand, what favors the venetoclax approach is you get to a limited duration treatment, and that can be an advantage because some patients don't want to be on the treatment where you right now have to say, well, it's going to be for several years until we have a better solution if you go with a BTK inhibitor. So there are pros and cons, and you could also argue if a patient has a history of atrial fibrillation, or right now has atrial fibrillation, or has other cardiac arrhythmia issues, has a high risk for fungal infection, which is something we could also discuss, which is an emerging concern with BTK inhibitors for maybe a small group of high-risk patients. Then sometimes you may lean more towards venetoclax-based treatment based on concerns around BTK inhibitor side effects. So it is, in my opinion, right now, since we don't have comparative study data, it's a case-by-case decision where you really have to look closely at risks of each patient for developing maybe problems, side effects with each of these agents. That's how I would approach it. There will be a study that's going to help us with that, which is the CLL 17 trial by the German CLL study group, which is going to compare ibrutinib with venetoclax obinutuzumab versus ibrutinib plus venetoclax. But until we have those data, many years are going to pass, and until then, I think we're going to be in this situation where we have great treatments. They are all good choices, but there are certain nuances for each patient where we can take patient preferences and certain risks for developing complications into account. That's kind of how I would go about it.
Yeah, I think I really use a very similar approach in taking it, having a discussion with patients, and some of it's very practical about, like you mentioned, can the patient come in for the ramp ups that's all involved with venetoclax, and some it's harder, especially older patients, coming to the clinic that often. On the other hand, when you sort of outline it's a time-limited therapy where it's for a year, then many people are willing to make that. But you mentioned, I think, fortunately, we're in a great position. Both approaches, a BTK approach versus a venetoclax approach, are really fantastic therapies where a period of equipoise, we really don't know which is better. And both are reasonable, but the field is moving forward, and we're now moving on to even more effective regimens, either by adding a BTK inhibitor with venetoclax, or the third drug of obinutuzumab, or a variety of scenarios there. And so anyway, I think it's an interesting time. We didn't talk about TLS risk. Frankly, there aren't that many patients that I can't manage with TLS risk as an outpatient, either by starting with obinutuzumab and debulking them, but it's rare days. I don't think you can manage that effectively as outpatient. So that really doesn't make my decision that I can't manage them as an outpatient.
Yeah, that's a good point you're bringing up. I think in the early clinical trials with venetoclax, we used to admit patients to the hospital for TLS monitoring if patients were considered high risk. But we've learned, I think, if we use precautions, if we debulk patients prior to increasing venetoclax, that I think the vast majority of patients can be managed outpatient. So there's early concern that we would have to admit most of these patients if they are high risk. That's not so much a concern anymore.